I'd like to welcome everybody back to the NBCC Code of Ethics 2023, Part 5 of 8. I am your host, Dr. Dawn-Elise Snipes. In this section, we're going to review the Code of Ethics and talk about assessment and testing, test interpretation, and research. Counselors shall protect the confidentiality of client tests, assessments, reports, and data. If you're having clients do assessments and testing, those are just as much a part of the confidentiality thing as your progress notes. So it's important that you are cognizant of those tests and assessments and reports. You are aware of who has access to them. If, for example, you are using a test that has a virtual grading or scoring platform that is hosted on the cloud, you know you need to have a business associate agreement with whoever is hosting that cloud infrastructure. Counselors shall not release any information related to the client, including the results of tests and assessments, to any other party other than the client without written consent, except as required to prevent clear and imminent danger to the client or others, when authorized by written agreement, when legally required to do so by a court order or governmental agency. Now, I can't think of any situation, and if you can think of some, please share, but I can't think of any situation in which the client's test data would be needed or appropriate, even if they're doing something like the Beck Depression Inventory or some other version of a suicidality assessment. That is one tool. You're not going to make be-all, end-all decisions based on the score on one tool. Everything is in context. So it's important to consider some of those things. Counselors shall use or interpret only the specific tests for which they are qualified. And a lot of people are like, huh? When I was working in community behavioral health, we were given tests. They were like, you're going to use this test and it's part of the electronic health record now, and you're going to administer it. You're going to administer this test. And this was, the SASE was still a paper pencil test. And that's going to be part of the client's assessment process, bada bing. But if you look at the qualifications, if you go on like Pearson's website and look at the qualifications for administering a lot of these tests, a lot of individuals may not meet those criteria. However, there's a caveat that if you're doing it as in an agency under the direction and supervision of somebody who is qualified, you can, in most cases, you can use the test. So it is important to be aware. It's also important, if you're in private practice, to be aware of what tests that you are able to administer. Level A, anyone can administer these. These are your trade and vocational proficiency tests, like your CGOE and interest inventories, those sorts of things that are not going to give you any clinical information, I guess. And, those of you, if any of you are rehab counselors, I apologize. I was trying to find a different word for that. But we know work is a big part of people's lives, but what I'm talking about is their trauma, their depression, their anxiety. So level B, master's level counselors and specialized training or a license or work from an accredited institution. Or work for an accredited institution. So if you are working in a university, if you are working in a hospital that uses this as part of their paperwork, then ethically you need to be trained in applying in administering the test and interpreting it, but you can do it even if you don't necessarily have that master's degree yet. Autism and ADHD tests for, to assess people's, whether they've got autism or ADHD or where on the spectrum they are. Those are actually level B tests. So anybody with a master's degree and specialized training, or a license, so if you're an LMHC, LPC, LCSW, LMFT, you can administer those. Again, with the specialized training. You need to know what you're doing. You don't just pull it out of the box and go, here, try filling this out and let's see what we get. Level C tests, you have to have a doctorate in psychology, education, or a related field with formal training in the ethical administration, scoring, and interpretation of clinical assessments related to the intended use of the assessment. Licensure or certification to practice in your state in a field related to the purchase. And it was a little unclear here whether you had to have a doctorate and a license, or again, you just had to have a license in the field. Because remember, level B, you don't have to have a license. You have to have a master's and specialized training or a license. So my understanding is level C would be a doctorate or licensure in your field. But Pearson would clarify that for you because they won't sell you a test that you can't administer. Counselors shall only use current valid tests and assessments specifically necessary for the provision of quality services and that have been carefully considered in terms of the instrument's validity, reliability, psychometric limitations, and appropriateness for use with regard to a particular population or client. You're not going to use a test that's been normed on adults with children and vice versa. You're not going to use a test that has been normed on college students for somebody who is not in college. Unfortunately, a lot of things have been normed based on college students when we're talking about the age range. But depending on the test, it may not be generalizable. The results you get from the college students to someone who never went to college or someone who's not in college right now. We do need to be sensitive. Cultural considerations, also hugely important. We need to make sure that we're using the tests that are specifically necessary for the provision of quality services. It's not just another way you can bill. Sorry, hate to have to say that, but some people do. It's like, ooh, we can run these 15 different tests, and can you imagine how much we can bill for that? No, that's not ethical. That's not okay. If you can't identify to the client and to the payor, this is the reason we need to spend this time administering this particular instrument. If you can't explain that, then it's probably not a necessary test. Appropriateness activity. The age of the client. And if you go onto Pearson's website and you look up a particular test like the MBTI or the SASE or something else, it has real clearly there the age range that it's appropriate for, whether it's 17 and above or, 3 to 6 or whatever. So you need to make sure that the test you've selected is appropriate not only for the diagnosis or to get the information that you're looking for, but also for the age of the person. You're not going to administer the Beck Depression Inventory to an 8-year-old. It's not appropriate. We need to make sure it's appropriate based on culture and whether the questions are written in such a way to be culturally validating to people, and making sure that we're not using instruments that stigmatize someone or discriminate against someone because of their cultural beliefs. We need to consider their cognitive and developmental status. And I will also put in here their literacy status. Giving somebody a paper pencil test, if English is their second language, not going to probably be appropriate. Giving people a paper pencil test if they are functionally illiterate, not probably going to work very well. So we do need to be sensitive to that. We also need to be sensitive to the fact, and a lot of people don't really recognize this, that a paper pencil test that is meant to be completed by the individual is, if you read them the questions and take the answers down, that's actually potentially skewing the results. People are often a lot more forthcoming when they answer paper pencil tests for themselves. If they're having to respond to you, they may hide some things or give deceptive answers. And we do need to be cognizant of how we are administering those tests. Cognitively, you don't want to give someone a 150 question test if their attention span is 10 minutes. Developmentally, we need to consider, again, in their cognitive development. Somebody can be 20 years old and developmentally, cognitively, not be at the level of a chronological 20-year-old. We see this a lot in fetal alcohol spectrum disorders, in which people with FASDs can often talk a good game. They talk really well, interacting with other people, but they don't process the information they're getting back very well. So they can say things that sound really, adult, like a 20-year-old, but what they're receiving in return and the way it's being processed when they get the information can be on the level of an 8 or 10-year-old. And we need to understand the nuances. If you work in substance abuse facilities, my feeling, my experience, my belief, whatever we want to say here, all of the above, is that a lot of people that you're working with may have some level of fetal alcohol spectrum issues. Not everybody by any means, but we do want to look and see behaviorally and cognitively if the person has some of these symptoms, and then investigate further. If you're not familiar with fetal alcohol spectrum disorders, not everybody with FAS has the facial features that are supposed to be the, quote, clear definition. No. Some people don't have the facial features, but they do have the cognitive deficits. We need to consider also their cognitive abilities if they're intoxicated, if they are experiencing dementia, etc. As I mentioned in the last presentation, if you're working with clients with dementia, some days they may be extremely lucid and able to complete a brief activity. Other days, they may not be able to. And we need to recognize the appropriateness and how that's going to skew our results when we take it, whether they're lucid or they're having a bad day. The setting is also important. If you are administering, and I'll use the SASE again, when you read the questions in the SASE, it's pretty clear what you're supposed to answer. If someone is answering it truthfully because they want help, then they're going to get very accurate scores. If someone is court ordered and they don't want to admit that they've got a problem, it's very easy to answer the correct way, quote unquote, to be identified as not having a substance abuse issue. And the criteria for deception, it picks up some, but not all of the deception. And then again, we want to consider the benefit of testing. Is there something I can glean from administering this assessment that I can't from just talking to you, from asking you a few questions, from, developing rapport and exploring things. Testing can be neat, but a lot of times it is so impersonal, and there's always some question. And as I said earlier, you can't take a test and use that as the be-all, end-all of diagnosis and treatment. You know, the test says this, so this is what we're going to do. Even in medicine, that doesn't always work. If you take a blood test and it comes back that you're anemic, well, we need to figure out why you're anemic. What's going on that's causing that? The test only told us that you were anemic. Beck Depression Inventory. It only tells us that you are depressed. Now we need to evaluate the symptoms, figure out what's going on, and how to intervene. In terms of test selection, prior to the use of a test or assessment with a client, counselors shall seek information about a test's normative groups and limitations of use that may affect the administration or interpretation of results. That starts out with just going on to the test publisher's website, finding out what age group it was normed on. You can do a deeper dive if you're working with a multicultural population to identify whether it was normed on the populations with whom you are working. And to do that, you can go to the borough's Mental Measurements Yearbook. Sometimes you can find it there. You can also go to my favorite place in the world, PubMed, because the research that they do to validate these instruments is often published in PubMed. If appropriate, the counselor may provide a referral to another qualified professional who specializes in the evaluation of individuals with similar conditions. This referral shall be documented in the client's record. FASD, perfect example. In order to get an accurate diagnosis and a legitimate diagnosis, I don't know what we want to say here, there's a cognitive aspect to it, but there's also a neurological aspect to it. So we can't necessarily make this diagnosis by ourselves unless you also happen to be a neurologist. So if I suspect that my client has a fetal alcohol spectrum issue, I may refer out to a neurologist that specializes in FASDs to get an accurate diagnosis. Counselors shall follow administration and interpretation protocols for all tests and assessments, including the use of appropriate computer software. If it's supposed to be computer administered, you need to administer it on the computer. Don't do it paper, pencil, or what have you. There are very specific procedures for administering the test, just like when you took your GRE or your SAT or something else. There are very specific procedures for how that's administered in order to get the most valid and reliable results. Counselors shall understand and address any issues of access and disability when using tests and assessments. This includes literacy levels. This includes hearing. If it's an oral test and the person can't hear, we need to address that. If it is a written test and the person's perfectly literate, but they have poor vision, we need to use accommodations to make the text bigger, whatever they need to be able to see it. You also may be working with somebody who has, for example, Parkinson's disease, and they have difficulty filling in the little bubbles on Scantrons, or they have difficulty using a typical mouse on a computer-based assessment. So we need to think what types of technology or what types of tools are out there to help this person complete this test in a manner that is most consistent with the test guidelines. Counselors shall comply with the identified information and data security protocols identified by the test publishers when using published tests and assessments. You're going to protect the client's data, obviously, but you're also going to, if you're using the SASE, for example, and you buy a stack of SASE assessments. You're going to use those assessments. You're not going to Xerox them. You're going to buy new assessments when you need new assessments. Counselors shall recognize results that are clinically significant for a given client test and assessment. What are these cutoff scores? But, sometimes that's not 100% appropriate for that client. And again, I'll give you the example of blood tests. There is this range that your different values are supposed to be in, but not everybody naturally is right within that range. It may be a little higher or it may be a little lower than the average because that range is based on that bell curve. The counselor shall document the client's record how the results will be appropriately used in the counseling process, not just what the test reported. So if the test reported, they did the Beck Depression Inventory and the test reported, yep, this person seems to have major depressive disorder. All right, so what are you going to do about it? You did the test. There was a purpose to determine whether this person had major depressive disorder. Now, how are you going to use that information in the treatment process? If you have them complete the MBTI, or you have them complete the STAXI, or, there's lots of different instruments out there that are really cool if you're doing research, but not always practical or necessary in clinical practice. But it can be useful to help you identify particular symptoms that may need to be addressed. By the same token, for a lot of the diagnoses, you can just go into the DSM-5-TR and open it up and go, okay, that symptom, and that symptom. Counselors who develop tests or assessments for measuring personal characteristics, diagnoses, goal attainment, or other appropriate clinical uses shall provide test users with written, valid information regarding the benefits and limitations of the created tests. So thinking about your own practice, what types of instruments might you develop to make life easier for you? For example, there was a period a decade ago, I created a checklist, a symptom checklist that I was able to look at. Since we know that a lot of symptoms overlap in different diagnoses, I took all those and I deduped all the symptoms from the different diagnoses, and then I would look and say, okay, what symptoms does this person actually have, and what does it most closely meet? So it made it something that the client and I could look at and say, all right, these are your symptoms, but it was also helpful for differential diagnosis. Now, the DSM-5 or American Psychological Association has come up with the cross-cutting measures tools that are available on the APA website. And those do the same thing now. So there is something that is out there that's valid and reliable and, covers the same thing. So why would you use something that's not validated when you've got something that's validated? And you want to let clients know how the information, again, is going to be used. Counselors who develop tests and assessments shall identify to the users of the test other potential sources of comparable information, like the cross-cutting measures tools on for the DSM-5-TR, explain to clients and or provide written information on the importance of basing decisions on multiple sources rather than a single criterion. And I know I seem sort of like a broken record here, but too often people will forget clinical judgment when they are just looking at a test. Human beings are not as concrete as cutoff scores. So we need to consider maybe somebody scored past the cutoff score for depression today, but that's because they found out this morning that their mother died. That's traumatic. They're going to be in a worse mood today. It doesn't mean they're necessarily that they've necessarily got major depressive disorder. They may be experiencing acute grief. We need to provide complete information regarding the format of the test, the administration purpose, the desired outcome, risks, and limitations. Most of the time with tests, there are no risks or very few risks, especially these paper pencil tests, but there can be limitations, and limitations for how accurate it is, how reliable it is based on the person's presentation that day, based on how closely they match the group on which the test was normed. There's a lot of different things. So we don't want people to think that a test is going to give them some magic answer. And we need to ensure that the information provided is actually understood. If you're trying to create a test or an assessment, you're going to be doing research to validate it, to see, is this doing what I want it to do? Is it helping me better assess this particular aspect? If you're doing any kind of research, though, counselors shall protect the welfare of research participants by taking all appropriate precautions to prevent negative psychological or physical effects. Now, well, we'll get into that in a minute. Counselors shall protect the identities of research participants by appropriately disguising data, except when there's a specific written client authorization for an identified appropriate reason. So a specific authorization for a specific reason. We're not just having these open-ended releases of information. That's important when we're conducting research. Counselors shall provide critical information through an informed consent process to potential research subjects that will assist them in reaching a determination about whether they want to participate. And I want you to start thinking about some of those research experiments that we hear about now, and we think, how in the world did that get past the Institutional Review Board? This information shall include the research purposes, process, duration, risks, potential consequences, and procedures, as well as the participant's right to refuse or withdraw from participation at any time. We need to make sure research participants sign that informed consent, and we need to make sure that they actually are able to withdraw at any time. And if there's any chance that they may have some ill effects or be triggered in some way, we need to make sure that we have resources for them to make sure to mitigate any distress they may experience. Counselors will obtain written consent from the clients prior to the use of any research activities or experimental approaches. Counselors shall provide appropriate disclosure prior to research participation and appropriately report to and debrief participants regarding the subject and features of the study after the research data is collected, as well as clarify any misconceptions about the research. A lot of times when you're doing research, you're not going to hand them an assessment or have them go through a protocol and say, this is what we're looking for. That skews the results. So we're going to say, this is what you're going to do. And we'll explain what we were looking for when it's over. I had one colleague when I was in graduate school who was doing research on the level of people's cognitive functioning when they were experiencing pain. And as a research participant, I put my hands in an ice bath, and then I was asked to do things that normally would be very mundane, routine activities, like basic addition and multiplication and stuff. But as my pain went up, my cognitive abilities kind of went down because that fight or flight mechanism was kicking in. But it was an interesting study. I didn't exactly understand what we were doing when we were doing it, but then they explained it to me afterwards. This consent process shall also contain relevant information with regard to the recording of voices or images of participants. If you're going to record them in any sort of way, they need to sign that release of information. For research participants who are unable to give informed consent, Counselors shall document considerations concerning the potential subject's desire to participate and the legal guardian's consent to the subject's participation. If they're not able to give informed consent because they are a juvenile, but they're getting ready to participate in some sort of approach, to help address their ADHD symptoms or something, or if, for example, they've got dementia and they're really struggling with sundowning right now, and there's this new treatment to try to improve people's quality of life and reduce the intensity of the sundowning, then the person with dementia may not be able to consent, but their legal guardian can. So there are instances where someone who can't overtly consent may benefit from particular research protocols. Counselors conducting research with underrepresented groups must take into consideration their historical, diverse, and multicultural experiences and only use techniques and approaches based on established, clinically sound theory applicable to the underrepresented populations. So, question for y'all. How might research experiences differ for people with a history of discrimination or oppression? And when we're talking about research, we're also talking about outcome measures. For example, if your agency decides that they're going to implement dialectical behavior therapy in their addictions wing, and you have a treatment group that's getting DBT and a treatment group that is getting your standard treatments, and you're comparing to see which is more or less effective, that's research. And you really do need to have an institutional review board approval to conduct that research. People with a history of discrimination and oppression, and I'm just kind of going to start, I see Michelle's typing, may also be wary of participating in research if they're worried that their answers may get them, cause them to lose child custody or cause them to get into the system or somehow cause them harm if they're honest. Research experiences, remember, it's a power dynamic. It's way bigger than the counseling power dynamic because the researcher knows what's going on and why they're doing it, but the researchee, the subject, doesn't. They know what they're going to be doing, kinda, but they don't understand all the whys yet. So that person may feel very uncomfortable and not sure how or if it would be used against them. We also have situations, for example, when they're trying to do clinical trials, for example, early on, they were doing trials of Vivitrol for people who were detoxing from alcohol and who had alcohol use disorder to see if Vivitrol would help them stay clean and sober better than the other options that we had out there. And that again is research. We need to document, who's getting the Vivitrol and who's getting the other medications in order to determine what's effective. Nichelle points out that the research results and her experiences will be filtered through their history of discrimination or oppression, and that's definitely true. The results that come out could be interpreted by the individual as being discriminatory in some way. Michelle It says the oppressed person may assume they're not getting scheduled for the treatment, and this may affect results. That's very true. Especially if you're doing a blind study where you've got a treatment group and a non-treatment group, and they don't know which one, or if you're doing a double blind and the researchers don't know either, then the person who has the history of discrimination and oppression may assume that they're getting put in the no treatment group. So their expectation bias could potentially skew the results and prevent them from achieving gains that they might have been able to achieve if they're in the actual treatment arm of it. Oppressed persons may enjoy the research experience if they see it as an opportunity to be better respected, validated, understood, and cared for. Very true. I mean, a lot of us, my daughter participated in a clinical trial for POTS because she wasn't getting the treatment that she needed. And she's like, hey, let me go into this clinical trial and see if my experience can help educate them, number one, so they can help me better, but number two, so they can help everybody else who has POTS better. And that's true. Some people actually feel empowered by participating in research because they're like, hey, maybe I can finally get some frickin' answers. Counselors shall accurately report results of research, including limitations and variables that may have impacted the findings. Counselors shall take all appropriate and necessary steps to publicly correct errors in the published research and shall not employ deceptive techniques in research unless there are no alternatives and there is significant prospective scientific, educational, or clinical value to the research. That's where your institutional review boards come in so handy or important or whatever you want to say, because the IRB is going to look at it and go, there is no significant value to this, or the value is not significant enough to justify the risk. In all cases, counselors shall review potential techniques with and provide an explanation to participants during the debriefing and will not use any techniques that can be reasonably expected to cause harm. So, I'll take you back to Psychology 101. Milgram's obedience to authority experiment. For those of you who don't remember, Milgram had two people come in, and one person was supposedly given directions, and if they didn't do what they were supposed to do, then the teacher, I don't remember what the proper labels were, but the teacher was supposed to shock them. Now, if I remember correctly, the person that was supposed to be doing the task, they weren't getting the audio, so they weren't being told what they were supposed to do. And so, of course, they weren't doing it. And Milgram was studying to see if the head researcher was able to have the teacher continue to intensify the electric shock. How much would the teacher intensify that electric shock to please the researcher? It was kind of it was a barbaric experiment. There are other situations where they had a teacher supposedly shocking the person on the other side. The person on the other side wasn't getting shocked, but they were acting like it. So they were a faux participant. And the idea was to see how submissive the shocker would be despite seeing this person like writhing in pain, and how much would they do it in response to an authority figure. So that one, I mean, we can see how that would cause harm to somebody. Number one, walking out of there going, I can't believe I just inflicted this pain on another person. To the, mainly to the person that was inflicting the pain, who's like, I can't believe I did that. or I feel bad that I quit on something. You know, people who really want to please may feel bad about themselves because they didn't do what they were told to do. It can be very triggering, especially if somebody came from a traumatic background, a traumatic household, to disobey authority. But by the same token, it's traumatic to hurt someone else. Zimbardo's Stanford prison experiment. Most of us remember this one too. The college students came in, some were assigned as guards and some were assigned as prisoners, and they were observed for a period of time. The guards got very full of themselves and their power and became very abusive toward the prisoners. So, I mean, we do see that absolute power corrupts absolutely, but at what cost to the prisoner subjects, and and how did it change the psyche of both the prisoners as well as the guards henceforth? And then we have Bandura and the Bobo doll. This was to examine social learning of aggression, and the children were put in two different camps. One was shown a benign film. Another one was shown a film that had more aggression. And then they were put into a room with this big blow-up Bobo doll. And the children who watched the violent videos displayed more aggression toward the Bobo doll. And so they're like, well, you know, I think this is probably the beginning of them saying that cartoons cause violence or whatever. But that was the goal of the experiment, to see if people could observe aggression and it would make them behave more aggressively. And sure enough, it did. But let's think about children, how much plasticity their brains have. Oh my gosh, you know, they're just learning and soaking it up and forming all these new neural connections. And how much of an impact did it have in their little brains 10, 15 years down the road after experiencing this? Maybe it was nothing. Maybe it was a short enough experience that it was just kind of weird, but the child de-escalated and went back to their normal behaviors 48 hours later or something. But we don't know. At least I don't know. I don't think I've ever seen any follow-up studies on the Bobo doll children. Have any of you seen any of the follow-up studies on that? I may be dating myself here too, because you may not even talk much about the Bobo dolls and Zimbardo and Milgram anymore. Those were three of the more traumatic psychological experiments that really made us realize that even things that seem sort of benign could have extenuating consequences, and an external review board is always helpful. I agree, Christina. I heard about them in undergraduate psychology 101 and never really heard about them again. I think because in large part as a profession, we don't really want to talk about those experiences anymore, but we can learn a lot. Prior to conducting research with students, counselors shall carefully follow ethical standards, including requirements regarding participant, supervisee, and client confidentiality, and multiple relationships. Now, this, again, was a little unclear. Are they talking about a supervisor doing research in conjunction with a student? I know that happened a lot in my graduate program. Or are they talking about a researcher conducting research on students? Either way, we need to make sure everybody has informed consent and is aware of confidentiality and multiple relationships. Counselors shall not indicate to students or supervisees that research participation is required or will otherwise negatively affect academic standing, supervision, or counseling services. If you're asking your students to also be research participants, I would go a step further and say we need to overtly inform them that it will not negatively affect their academic standing, supervision, or counseling services. It will not affect them. And then obviously we need to make sure we uphold that. So if somebody doesn't want to participate in our research study, that's okay. Counselors shall comply with the applicable guidelines when designing, conducting, or reporting research, including those of the relevant institutional review board. For those in private practice without access to an IRB, or for many of you who are in community behavioral health treatment facilities, you may not have an institutional review board that oversees research if you don't routinely do research at your organization. If so, that's fine. Submit the research proposal to an external, federally registered, very important, federally registered IRB board, such as those associated with community hospitals or independent IRBs. The independent IRBs are not cheap, I will tell you, but for an organization, if you don't normally do research and you want to do this one-off, it's not, unheard of. It's a couple $1,000s. But if your agency is regularly going to do research, then they probably want to become a federally registered institutional review board. Not only does that mean they can approve in-house studies, but that also means they can approve studies from other behavioral health agencies and private practitioners and make some more money. Even if the research is conducted in a private practice setting, if it involves systematic investigation designed to contribute generalizable knowledge, IRB approval is necessary. So if you're going to decide that, hey, I want to see if using dialectical behavior therapy with people with CPTSD or something is more effective than standard talk therapy, then you certainly need to get IRB approval because you're comparing two different treatment conditions. Counselors shall comply with the intellectual property laws and accepted publication guidelines, shall credit the work of contributors, including students who have contributed to the research, shall take credit only for research activities they have performed or authored, and when quoting the work of others, counselors shall provide appropriate citations and references. Now, we can go a little bit overboard citing every single thing. If you have like half a thought, then trying to figure out, well, where did I learn that and cite that person. But it is important to give credit where credit is due. If you're talking about Linehan's research, make sure that you're giving Linehan credit. In this section, we reviewed the NBCC Code of Ethics point by point. We talked about assessment and testing, choosing appropriate tests and only using tests when necessary. We talked about test interpretation and research. Are there any questions? I don't know how many of you are professors or adjunct professors. If you teach ethics, it can be interesting, like in this section, if I were teaching to a group of students, we would have gone through this, and then I may have said, go into PubMed or go into your psychology books from undergrad and find some research studies that were done, and let's talk about how that research contributed useful, generalizable knowledge, and talk about any potential harm that the researchers needed to consider, and if you were doing the experiment, how you would have addressed that or something. Really getting people to start looking at research. But all right, we will take a 10-minute break, and we will come back at 10:30.